Good morning. Thank you very much again for the most kind invitation to be here today. The topic of my talk is minimally invasive surgery in gastric, neuroendocrine, and stromal tumor. I have no disclosure. Okay. So we are addressing a topic on rare cancers. And rare cancer is a challenge. It has been recognized since 500 years ago that studying rare cancer could change the game by William Harvey. This extraordinary vision. And what are we learning from rare cancer is that we are moving quickly toward a more personalized approach to therapy. It is very surprising, but it is truth. So, two different entities with similar clinical presentation. We will not go through clinical aspects, but both tumors are presenting as a localized mass in the stomach wall, gastrointestinal stromal tumors, GIST, and neuroendocrine neoplasia. Radiological diagnosis helps a lot to suspect the correct diagnosis, as you can see here, but it is absolutely not sufficient to decide the therapeutic strategy. And we need extensive biopsy specimens. We will first of all address gastric neuroendocrine neoplasia. Based on the WHO classification, neuroendocrine neoplasia needs to be very clearly distinguished in two different entities. The first one is well-differentiated neuroendocrine neoplasm, that is the NET tumors, and the second one is the neuroendocrine carcinoma. Very different histological aspects and very different prognosis. Classification and treatment. According to the WHO agreeing, classification of neuroendocrine neoplasia is based on the cellular differentiation. So NET, G1 and G2 are well differentiated, are low or intermediate grade, and a Ki-67 index less than 3% in very well differentiated G1 tumors and up to 20% in intermediate tumors, G2. NET G3 are high grade with a Ki index more than 20 and start to become dangerous neoplasia and very aggressive neoplasia. And obviously, as I told you before, neuroendocrine carcinoma are small cell and large cell, poorly differentiated, very aggressive neoplasia. So according to this classification, we can say that type 1 NET, very well differentiated, often multiple tumors, less than 1 centimeter, associated with atrophic gastritis or pernicious anemia, account for almost 78% of the cases in the stomach. And type 2, again, multiple, less than 1 centimeter, associated with Zollinger-Ellison syndrome, and men type 1 are well differentiated and are less than 5% of the cases. While type 3, solitary 1 or more centimeters ulcerated tumors are around 15 to 20% of the cases. Type 4 carcinomas are rare. We are lucky. Regarding the algorithm of treatment, as you can see here, for type 1 and type 2 tumors that are well-differentiated tumors, you see endoscopic resection is appropriate in localized lesions. Gastrectomy with lymph node dissection is done in case of tumors more than 2 centimeters and more than 6 different nodules. And gastrectomy with lymph node dissection, as we just saw in the amazing presentation of Professor Kinoshita, is the operation of choice, and type 3, poorly differentiated NET. But again, if after endoscopic resection, we see that the muscularis propria is invaded, lymphatic invasion is possible and lymphatic metastasis is possible. So gastrectomy with the lymph node dissection again. So surgery for the NET is in most cases typical gastrectomy. In this case, this was 1 centimeter diameter. We performed a combined laparoscopic and endoscopic procedure, but it's quite rare. So regarding neck carcinoma, neuroendocrine carcinoma, both small and large cell have a different workup. The FDG PET and the somatostatin receptor-based imaging usually not very helpful, and treatment, multimodal treatment, is advised for the majority of patients. And surgery again is a total gastrectomy or a subtotal gastrectomy with a D2 lymphadenectomy. In advanced disease, medical treatment is the mainstay, but again, surgery can be indicated after treatment just for palliative or debulking reasons. So consider surgery also in this advanced setting. What is changing the treatment are the new therapies. You see here clearly that the lutetium dotatate has changed the prognosis in these kind of cancers. So again, multimodality treatment and MDT discussion is mandatory. Now we move to the gastric cyst. These are the most common type of sarcoma. So most common mesenchymal tumor of the GI tract originating from a common precursor of the interstitial cells, but common finding at autopsy series. Around 20% of autopsy cases show some minor subcentimetric lesion that is a well-differentiated cyst. But all cysts should be considered potentially malignant. This must be kept in mind when we find a mass in the stomach or in the esophagus. Regarding tumor spread, very differently from neuroendocrine neoplasia, lymph node metastases are extremely uncommon in cysts, and this changes the game of surgery. Few words on diagnosis and mutation. Well, what has really changed the game is that we need to find the mutation in cyst. And as you can see here, when c-KIT and DOG1 are positive, we have the diagnosis of cyst. And in gastric cyst, as you can see here, KIT exon 11 mutation accounts for almost 60% of the cases, 5% exon 9, PGFRA 15 to 20%, and other mutation 10 to 12%. There is a rapid evolution of research in this field, so things are changing rapidly. And we need only to evaluate the c-KIT mutation, but also the PGFRA and rarer mutations that are now researched routinely. There is a progression from benign microgist, absolutely not dangerous, that can be left in place, and proliferating cyst, changing the cell cycle, up to the invasive metastatic cyst that is really malignant neoplasia. And as you can see here, the research on c-KIT and tyrosine kinase has really changed the game. This is the publication of the New England dated back 22 years ago that warranted the cover of the Time, because this was a really advancement in the concept of treating cancers. As I told you from the beginning, research on rare cancers is quite important. And now research is focused on different kind of drugs. You see, from imatinib to dovitinib. As soon as we get accustomed with one name, they change the name. I think that the oncologists are trying to challenge us. So GIST prognostic factor are based on size, mitotic count, more or less than 5, site of the lesion, status of the margin of resection. But unfortunately, mutational status is not incorporated in risk classification up to now, and that we strongly believe this will be the next step. Again, as you can see here, the famous Mettinian classification. We will not go through all these classifications, just saying that low-risk GIST are less than 2 centimeters in diameter, and high-risk GIST are more than 5. But you need to combine also the mutation index and the mutations. According to all these parameters, it is possible to predict the prognosis of GIST and to decide the therapeutic pathway of your patient. So the big change of the last years has been neoadjuvant treatment of GIST. If we look at surgery, the mainstay of therapy for GIST without metastasis, well, it's the initial therapy. If the tumor is technically resectable with acceptable risk of morbidity, both in terms of preserving organ function and postoperative risk for surgery. Both large tumors and poorly positioned small GIST that are considered marginally resectable. Well, in this case, neoadjuvant imatinib is strongly recommended. The main goal of surgery is complete resection with an intact pseudocapsule and negative microscopic margins with no dissection of clinical negative lymph nodes. So no dissection is not necessary in the absence of evidence. If we look at the algorithm of the treatment choices, we clearly see that in localized GIST, when surgery is possible without organ, with the preservation of organ function, what surgery is the first step. But if we have the risk of R0, R1, R2 surgery, or major sequelae, well, the good choice is neoadjuvant imatinib. But please avoid, every effort must be done not to rupture the pseudocapsule of the gastrointestinal stromal tumor. This is high risk, carries a tremendous risk of recurrence. There is some discussion about the resection margins in GIST. Reports about the prognostic of resection margin and clinical value of R1 surgery are controversial, and therapeutic strategies of R1 resection remains uncertain. Also, we have strong bullet with imatinib and similar drugs now. There is also some place for surgery in advanced metastatic disease when the patient responds to imatinib or similar drugs, and surgery has two possibilities of becoming radical if there is a major response, or palliative in case of progression on one organ site. Surgery in advanced disease carries a good prognosis. Again, you see, in response to therapy is the main driver. Now I will show you some short videos now how we do it. I want to show you the CT scan of the GIST located in the esophagogastric junction here. Huge GIST, c-KIT mutated. Post-treatment 12 months imatinib. You will see major response, totally changed. unfortunately, the procedure cannot be very conservative, so we decided for a laparoscopic high-volume resection without extended lymphadenectomy. This is the section of the cardia, the esophagogastric junction. We'll go quickly, just to show you that we will not proceed with D2 lymphadenectomy in this case. Tissues show some degree of scar tissue and fibrosis around the cardia where the tumor was located. This is the passage between the right and the left diaphragmatic crus. We follow the plane, the vascular plane, because it's easier, but we don't need to perform an extended lymphadenectomy in this case. We will prepare the stomach we'll go quicker here, for an high-volume procedure, clearing the lesser curvature. Gastric tube fashioning, as we do in adenocarcinoma. Very similarly, we keep a gastric tube around 4 to 5 centimeters in width. We don't complete the gastric tube fashioning, we will do it in the chest. And here we are approaching the cancer. You see, there is a pseudo-capsulated tumor here. Sorry, yeah, it is. This one. Quite different from the beginning. It looks a bit frail, so we need to take a lot of attention to the pseudocapsule. This is the histologic exam after surgery, and what is, you can see very surprisingly, there is only a minor residual viable cells inside a lot of scar tissue here. One could argue if we can limit surgery in these cases, but it's too early. This is another case, much easier. Sorry. Yeah, you see? We dissected the lesser curvature. It's in the upper part of the stomach, but sufficiently away from the junction to perform a wedge resection. As you can, I will show you after, sometimes we use intraoperative ultrasonography to localize the base. And it's easy to perform a wedge resection with a transverse approach to the body of the stomach, between the body and the fundus. Then we retrieve the specimen that is intact and oversee the suture line. This is the final result set. Also, in this case, the patient was pre-treated with imatinib. Now, I want to show you this short video just to show a possible technique. This was a leiomyoma presenting as a GIST just below the esophagogastric junction. I'll show you the abdominal CT scan. You see the mass is here, 4 centimeters. It's a challenge resection of such a lesion, in my opinion, because you need to preserve both function and to prevent reflux, postoperative reflux. We decide to approach the tumor laparoscopically, just below the junction here. We dissected the lesser gastric curvature, just a bit, just to approach the junction. The tumor is there. Flexible endoscopy has been performed during the operation, but we use ultrasonography to localize the GIST, to localize the mass, and to choose the point where we can approach the muscular layer and reach the capsule of the lesion, as you will see here. We cut the muscular layers, and we dissect the layers very, very gently and very carefully, just to find the lesion, and that in this part is very superficial. We cannot do exactly the same procedure for GIST because the danger of damaging the capsule is obviously too high. Also, if I wonder if this kind of operation will become possible when there is a major response to treatment, as I showed you before, the viable cells left are really very, very few. So this is the submucosal layer. The GIST has been, the leiomyoma has been removed. Integrity is checked both by echography, the layers of the wall are intact, and running suture will conclude the operation. So, in conclusion, these are rare cancers, and it's a challenge. Multidisciplinary approach is really mandatory, and also referral to high-volume center, at least for pathology revision and MDT discussion. Extended lymph node dissection for neuroendocrine neoplasia is mandatory in most cases. And in case of GIST, consider neoadjuvant treatment. Every effort should be done to preserve all organ and function. And surgical margin are important, but do not extend too much gastric dissection. There is no need in this case. Thank you very much.